delighted to introduce Dr. Deirdre Conroy, an expert in behavioral sleep medicine and the management of chronic insomnia. Dr. Conroy is clinical professor of psychiatry and clinical director of the behavioral sleep medicine program at the University of Michigan in Ann Arbor. Her work has been pivotal in advancing practical and evidence-based approaches to insomnia clinical care. We're delighted to have her share her insight on chronic insomnia disorder, diagnosis, and management. Please join me in warmly welcoming Dr. Conroy.
Hi, everybody. My name is Deirdre Conroy. I'm a clinical sleep psychologist at Michigan Medicine, and I'm here today to talk to you about the evaluation and management of chronic insomnia disorder. I have one conflict of interest to disclose, and that is I am a scientific advisor for a company called Stellar Sleep, but that should have no impact on my discussion with you today. I have a few learning goals for us today. One is to share with you the scope of insomnia and how we currently understand it. And then I'm going to be talking about what are the current practices that you should know about in terms of deciding your treatment with your patient, and how to assess for insomnia and what to keep in mind in terms of treatment. Now, the insomnia landscape has changed over the years, and I want to cover how it's changed and where it may be going. And then finally, we're going to be talking about what does the future look like for insomnia treatment. So let's jump in. How common is insomnia? Well, studies have shown that insomnia is present in about 1 in 3 individuals in terms of having brief insomnia symptoms. So 1 in 3 people have sleep disturbances, and 75% of adults age 65 or older will have trouble sleeping. And 20% of younger people or preteens have experienced insomnia symptoms. So in all, about 1 in 10 people struggle with chronic insomnia, so about 10% of the population. Who is most affected by insomnia? 3 categories emerge. So mostly females, mostly individuals who are older, and those with mental or medical complications. Now, the impact of insomnia seems to be more likely in women than men. So 40% of women are more likely to be impacted by insomnia, as you can see here. So how do we define it? One thing is that the way that we understand insomnia is that it is a disease in its own right. And this has been described both in the DSM-5 and the ICSD-3. Insomnia can be diagnosed independent of other conditions, any other coexisting either psychiatric or medical disorders. And we do have a frequency criteria, although this does become more relevant for things like research protocols. But keep in mind that you want to look for at least 3 nights a week for at least 3 months to classify as chronic insomnia. And this is different from insufficient sleep. So it isn't the person that's too busy to sleep doing other things. It's the person that's trying to sleep and struggling to do so. So not due to insufficient sleep associated with purposeful or intentional sleep restriction. And the way we understand insomnia is that it's a 24-hour disorder. That is, there are nighttime symptoms. So the nighttime symptoms can include dissatisfaction with sleep, trouble falling asleep and staying asleep, but also impacting the daytime functioning. So impaired concentration, changes in mood, performance, and so on. So what we typically hear is the patient telling us that they're having trouble falling asleep, staying asleep, waking up too early, and having dissatisfaction with their quality or quantity of sleep. These symptoms must be associated with some impairment of daytime functioning to warrant the diagnosis of insomnia. Now, this daytime impairment can vary widely from person to person. I typically ask an open-ended question to get information about how the insomnia is impacting one's daytime functioning. But to give you some examples, some of the daytime impairments may include things like fatigue, sleepiness, mood disturbance, behavioral trouble, negative impacts on the family, concentration problems, and so on. So it really does vary widely from person to person, but the point here is that you're going to have both nighttime symptoms and daytime symptoms. There are clinical subtypes of insomnia, and for further reading, I would guide you to the ICSD-3, where the manual breaks down chronic insomnia and all of its subtypes. But we know that we have acute insomnia and chronic insomnia. Acute insomnia may be associated with acute stressors. Something happens in one's life, and immediately they start experiencing trouble sleeping. There can be many other causes to the insomnia that may include medications or substances, that can include medical or neurological disorders, so insomnia due to a medical disorder. We can have insomnia due to a psychiatric disorder, or not due to any of those, so primary sleep problem. When we think about the reasons why we develop insomnia, it could be multiple. So circadian or body clock issues can be a culprit. Behavioral changes or habits over time can start affecting sleep. And we can also have genetic factors that can contribute to both the onset and the maintenance of insomnia. So to look at this a bit more closely, we have a slide here that takes into consideration the 3P model of insomnia. Now, the 3P model is the predisposing, precipitating, and perpetuating factor model that Dr. Spielman developed as early as 1987. And since that time, we have many different characteristics that have evolved in terms of explaining what insomnia is. I won't get into all the details here, but I want to kind of show you this flow chart and show you that the predisposing factors can be lumped into generally 3 categories that are genetic predisposition, neurobiological predispositions, and even personality characteristics that can play a role in one's tendency to develop insomnia. So, for example, perfectionism or neuroticism, emotional suppression, how one deals with emotions and mental health. But then as we move to the center of the screen, there might be a precipitating factor, something that happens in one's life. So a loss of a job, loss of a spouse. And as time goes on, there may be other factors that perpetuate the phenomenon, which could include anything from cortical arousal or not feeling like you're ever getting sleepy, this hyperarousal, memory problems, or behavioral adaptations. So if I'm not sleeping well, I might try even harder to sleep by spending excessive time in bed or napping or sleeping at irregular times. This in turn might impact my cognitive performance and in turn affect emotional regulation. So we think about these factors as feeding on each other. And the perpetuating factors are important because those are the factors that are feeding the insomnia, that give it its life, and that are most receptive to treatment interventions. And that's where we kind of come in to assist the patient with the symptoms of insomnia. So let's say you're seeing your first insomnia patient in the clinic. How are you going to go about assessing that person? The one question that we start with is general, and that is, what's the most disturbing part of your sleep? And allowing the patient to provide information about whether it's difficulty falling asleep at the beginning of the night, or maybe staying asleep, they have trouble waking up in the night, or waking up too early, that is waking up and not being able to get back to sleep, or difficulty waking up at the intended time. And oftentimes it's difficult for individuals to remember details about their sleep. So keep it recent. So have the patient focus on about their last week. And if it's not a typical week, ask them, in a typical week for you, do you experience trouble falling or staying asleep? Just to indicate whether they're talking about something that's unusual for them or more typical. And as I was saying, in terms of affecting one's functioning, you want to ask about how the insomnia is impacting their life. And I'm listing many examples here that I mentioned earlier: mood, energy, concentration. Does it make pain worse? Does it cause sleepiness? Are you feeling fatigued because of your sleep disturbance? So you're starting to get a sense of what's going on during the day as well. So if you think about the timeline or the areas that you're going to be assessing, you want to think about it as a 24-hour period. And so the figure to my right is from an article written by Dr. Morin, who is a pioneering sleep researcher, and Dan Bizey. Both have done a lot of work in our understanding of insomnia. And what they're showing here, just all the questions that you can ask about the different time periods of the day. So if you start with the nighttime, you'll be asking what time they go to bed, how long it takes to fall asleep, how many times they wake up, what time they get up in the morning, but also what's happening during your day. What are your obligations? Do you work? Are you dozing during the day? Do you get exposure to light? Do you go outside? How much are you eating, or when are you eating? Do you eat right before bed? So we really assess the 24-hour period and not just the symptoms that are occurring at nighttime. So when we're asking about the daytime, here are some questions you might consider. In terms of daytime napping, if given the opportunity for a nap, would you be able to fall asleep? And if they do nap, you want to assess the timing, the frequency, and the duration. Now, it's not unusual for someone to say, I don't nap at all and I don't feel sleepy at all, because of that level of hyperarousal that's very common in insomnia. But if they do experience sleepiness, you're going to quantify that. And I often sometimes use the word dozing instead of naps. Do you doze off unintentionally? Naps can sometimes mean an intentional manner, and sometimes that can mean different things to different people. So do you doze off? And if so, how much and when? And what's your daytime activity like? Are they getting enough activity during the day, or are they overactive, meaning they have no downtime during the day? So once you've acquired information about their typical patterns during the nighttime and daytime, now it's time to introduce the patient to a tool to further assess their sleep for follow-up care. Now, one of the tools that we use in assessment of insomnia is the sleep diary. The purpose of the sleep diary is to have the patient track their sleep patterns throughout the intervention so that we can see prior to intervention, during intervention, and if you're seeing them in follow-up, how does their sleep change over time? This can assist you with improving your case formulation, and it can help guide treatment decisions. Now, in years past, we would use a paper and pencil format. We would hand that to the patient and ask them to log their sleep patterns. As you can see here on the left-hand side of my screen, there's several questions about their night that they'd fill in every morning. Or on the right-hand side, in some people, it's better to have them fill in the boxes to understand when they're sleeping across a 24-hour day. But it's some way for them to give information about their subjective sleep patterns. We don't use the paper as much these days because we have a lot available to us with the use of apps or online sleep treatment programs, some that I'm showing you here, things like CBT-I Coach or Stellar Sleep, or Sleepio are some common assessment tools that include a sleep diary function. But the point here is to collect information outside of the clinic visit to help you guide your treatment decisions. So once you obtain the information in the clinic, you've used your tool to use a sleep diary to understand their patterns over time. And now you're going to be considering, what technique should I use next? So if we think about the approaches to insomnia, we really find ourselves with two broad approaches: medications, pharmacotherapy on the one hand, and cognitive behavioral therapy for insomnia on the other. Now, these things aren't exclusive. Certainly, someone can engage in behavioral interventions while taking a medication, so that's not to exclude these types of interventions. But what we're going to do today is talk a bit more about what the treatment options for pharmacotherapy are and what is cognitive behavioral therapy. Some of you may have read a lot about it, but we'll talk about what the interventions do and what their goals are. In terms of pharmacotherapy, we're generally talking about four main categories. We have general benzodiazepines. We have benzodiazepine receptor agonists. We have melatonin receptor agonists. And more recently, we have the dual orexin receptor antagonists. And I'm going to say more about the different types of medications in a moment. Now, the techniques we use behaviorally can include time in bed restriction. That is a technique in which we limit the time in bed to the amount of time the patient is sleeping based on their sleep diaries. Stimulus control is an intervention that we discuss that means if you're not sleeping, get out of bed, go do something else. So we encourage the patient to avoid remaining in bed, to think, plan, or use their phone, and instead get out of bed and wait until they're sleepy to return to the bed. Relaxation techniques are also included in a cognitive behavioral therapy for insomnia program. This might include things like diaphragmatic breathing, progressive muscle relaxation, and so on. And then there's the C from the cognitive perspective that includes things like cognitive restructuring. So there's a lot of data to support that individuals with insomnia develop dysfunctional beliefs about their sleep, like I should get 8 hours of sleep every night, or if I don't sleep well on a given night, I know that's going to interfere with my functioning the next day. And the goal here is to understand the thoughts that are coming up about sleep and to reframe those thoughts. And this is what happens in a therapeutic process over time. There are other techniques that are involved in CBT-I that you can read more about in further readings. So a word about pharmacotherapy. What I'm showing you here is a table including some of the common medications indicated for insomnia by the US FDA and or by the AASM, the American Academy of Sleep Medicine. And you can see we have the generic name, the brand name, the half-life, the typical dose, the drug class, and the indication for each medication, and SO meaning it's indicated for sleep onset, and SM meaning it's indicated for sleep maintenance. Now, many of these medications are used in various ways, not always for these specific indications, but sometimes it helps to understand that depending on the half-life of the medication, you want to be careful of when you're prescribing and what time you're asking the patient to take it, depending on sleep onset or sleep maintenance insomnia. And so to give you a sense, I've listed here the different benzodiazepines, including things like temazepam, triazolam, and for example, we are moving towards the BZRAs, things like zolpidem, zaleplon, esoplaclone, zolpidem ER, and zolpidem SL. And these are various forms of the BZRAs and the different medication dosages and time that they're the half-lives of these medications. The Melatonin receptor agonists include one, which is Rosarem, also called Ramelteon. And then we have doxepin, another type, a TCA, indicated for insomnia. And then the bottom three are the DORAs, or the dual orexin receptor antagonists. And those are more recent medications that have been approved for insomnia that are actually quite interesting. And so we know that these are addressing the orexin system, which is also called hypocretin. They were sort of discovered around the same time. And this is a neuropeptide that we know is involved in arousal, wakefulness, and appetite. Now, the orexin receptor antagonists are sleep promoting because they're blocking the arousal by the orexins. Now, it's important to know that, narcolepsy type 1 is related to orexin because it's caused by the lack of orexin in the brain due to the destruction of the cells that produce it. So this is also important when we're using a medication like a dual orexin receptor antagonist as it relates to possible side effects and the fact that they could potentially mimic symptoms of narcolepsy. So this is kind of one of the newer medications that's out there. So of course, this wasn't an exhaustive list of the medications. We can certainly talk more in detail about how the medications work, but this was just a primer of how these medications might be used for insomnia. And now I'm going to say a few things about the non-pharmacological options like CBT-I. So what's going on when we're delivering CBT-I? Well, this is a comprehensive approach that's targeting the factors that are perpetuating the insomnia. So remember at the beginning, I talked about those factors that give the insomnia its life, like the changes in the behaviors or the thoughts that the individual has developed over time. This type of intervention is rooted in science and the understanding of sleep-wake regulation and the principles of behavior change in psychology. It's shorter than many therapies out there. So it's much shorter than a therapy for, let's say, depression, which might be 20 or 30 sessions. CBT-I is a skills-based program that's relatively brief. It can range between 4 and 10 sessions, but approximately 6. It can be quite effective both individually and group. So there's lots of ways that we can deliver this intervention. And the goals are really to address the behaviors and the cognitions. So in terms of the behaviors, we're looking to increase sleep drive. We're optimizing the circadian placement and sleep opportunity. For more information about that, I encourage people to read about the two-process model of sleep and how that is regulated. And that's really the goal of the intervention, is to align the circadian system and the homeostatic sleep system. So we're strengthening the circadian clock by talking about things about the importance of keeping a regular sleep schedule, the importance of waking up every day at the same time. Using the bed for sleep, strengthening the bed as a cue to be asleep rather than to be awake, planning or reading or looking at one's phone. We really want to reduce that physiological hyperarousal that develops over time as a result of the insomnia. And how do we do that? Well, we talk about this phenomenon called sleep effort. So the more you try to sleep, the harder it can become. We try to learn about what are the thoughts that are getting in the way of sleeping and reduce that cognitive arousal. And also understanding what are the beliefs that the individual is carrying about their insomnia. They may believe that if I nap every day or if I sleep later on the weekends, that those are helping me sleep, but we might talk about sleep promoting practices and how that might be impacting them. And the thing is with therapy is that behavioral therapy can be sometimes hard to do. And so we sometimes will address the obstacles to engaging in something like this because changing habits is difficult. So how do we know that this is a valid treatment? Well, when we weigh the data, there have been 2 studies that have evaluated the evidence for the efficacy. And I'm showing you the kind of pictures of these articles here. One is in 2023, and it is from the European Insomnia Guideline, update on the diagnosis and treatment of insomnia, which show that these interventions, specifically like stimulus control, that is getting out of bed if you can't sleep and going back to bed when you are sleepy, and time in bed restriction are the most active ingredients of CBT-I. Similarly, in another article that came out in 2021, this was in the Journal of Clinical Sleep Medicine. This is a review article that goes through all the different types of interventions, like brief behavioral interventions, stimulus control, time in bed restriction, and weighs the data to suggest which ones are most powerful. And just kind of summarize here that these ingredients, these behavioral interventions, have really been shown to be valid and supported by evidence, most notably the time in bed restriction and stimulus control. And that's important for the busy clinician who doesn't have time to go through reframing thoughts or understanding the thoughts or beliefs about sleep. When we have a few minutes with the patient and we can talk to them about, hey, let's talk about changing your sleep-wake schedule. Have you considered getting out of bed when you can't sleep? It can be very powerful pieces of advice that you can deliver in a short time. So when you're in the office and you're discussing the options with your patients, you want to kind of think about this in terms of, am I going to go with a medication, or am I going to go with CBT-I, or maybe there's both. The advantage of a medication is that it's going to work quickly. It may be well tolerated. It could be very effective, minimal burden in terms of time. The patient takes the medication. However, there are side effects. There could be tolerance and certainly drug interactions. And there could be safety concern in certain populations, most notably the elder population, concerns for balance issues, and so on. With CBT-I, it's also effective, and we find that over time, the individual maintains the gains over time. There may be fewer side effects initially, and it may increase the patient's belief that they can do something about their sleep. So it increases what's called self-efficacy. The problem with an intervention with CBT-I is that the effects aren't always immediate. There are delayed gains. It's hard to do. It takes many follow-up sessions. You do need to follow the patient fairly closely, and it's less widely available. And I'll say more about that in a moment. So if we look at the key elements of insomnia and some take-home messages, we want to start to think about insomnia as its own disorder. So from the left hand to the right hand, I'm kind of going to walk through some of these key elements, and then we're going to go through them in more detail. So one thing to keep in mind is that the way that we understand this is that insomnia is a disorder in its own right. It should be actively treated even in the context of other disorders, or even in the active treatment of other disorders, such as mental health disorders, pain disorders, or even in some cases, addiction treatments. CBT-I can be also utilized. And as I've just talked about in these studies, that CBT-I has now been considered the first-line approach to insomnia. And it really should be considered as part of the treatment decision process. The other piece of this is this interesting bi-directional relationship that we have learned with various studies looking at mental health and medical issues and sleep, and looking at insomnia and insomnia contributing to mental health disorders, but also the other way around, mental health disorders contributing to sleep problems. So there's evidence that treating insomnia effectively may alleviate comorbid mental and physical conditions. The problem, again, comes up is about scaling this and making it more widely available. And that's where we start to get into the options, not only of providers, but perhaps also digital products in the market as well. And so there have been some of these products that have clearance, regulatory clearance, that can make these components of insomnia treatment more widely available. Now, the fact that CBT-I really should be considered as one of the first-line treatments has been noted for many years, as noted here, by many institutions as far back as 1999. In 2016, though, the American College of Physicians really kind of came out and identified CBT-I as a first-line treatment. And this has subsequently been repeated by other organizations and supported. So what the ACP said is that all adult patients receive cognitive behavioral therapy for insomnia as the initial treatment for chronic insomnia. And the second recommendation is really this shared decision-making process, including a discussion of the benefits and the harms, similar to what we were just talking about, the weighing the pros and cons, the costs of short-term use of medication to decide if a medication might be indicated. We do consider medications in a couple scenarios. One, in cases perhaps of acute insomnia and or individuals who have undergone insomnia and it was either unsuccessful or the patient has no access to CBT-I. Now, we also want to be careful with the words unsuccessful with CBT-I. Kind of always ask your patient, how many sessions did you take part in? What did you do? What was your active role in this treatment? Because certainly lots of patients might say they've done things like sleep hygiene, but that doesn't really cover the comprehensive nature of CBT-I. So this was a very important statement from the ACP that we consider now in our treatment decisions. And I'm showing you with a slide here. It's a little bit of a busy slide, but it's looking at the efficacy of CBT-I in many studies in individuals with either no other health conditions in these meta-analyses and with other medical or mental health comorbidities. And while it's difficult to see the exact the names of these studies, what I want to just point out is that what you're seeing here is that CBT-I is favorable to control or placebo conditions in individuals with no other health conditions on the left-hand side, as well as with other health conditions. And some of the, if you can't see it, some of those other conditions that CBT-I has been used in can include things like alcohol dependence, chronic pain, breast cancer, COPD, depression, PTSD, and other mental health disorders. So we can see that the CBT-I really does have more favorable results when used versus placebo, and in combination with starting other types of medications. And so I'd like to show this slide. This is a slide from a study that was done in individuals with depression using isoplaclone and fluoxetine. And so what you're looking at here on the x-axis is individuals after 4 weeks of using a medication called isoplaclone plus placebo, or fluoxetine plus isoplaclone. So isoplaclone is Lunesta, and it's was prescribed specifically for the insomnia piece of the depression. And on the y-axis here, we have the percent of patients achieving remission. And what we can see is that by week 8, 42% of individuals that were given the addition of the sleep aid were achieving remission, which was significantly different than those that did not receive the sleep aid. So this is highlighting this independent nature that insomnia it can be its own right, its own problem, and that if we address the insomnia in the setting of other mental health conditions, we may be able to influence remission. So how do we deliver CBT-I? Well, currently there are several ways, and historically, CBT-I has been delivered by psychologists, social workers, and more nurses, and even some physicians. And professionals should have a license to practice, to operate within the limits, of course, of their qualifications. And licensing and training bodies really should be involved. There is a Society for Behavioral Sleep Medicine that does oversee a lot of the delivery of things for behavioral sleep medicine. But we need to be aware of the individuals delivering this care so that they can receive proper supervision and training. But we may not need the fully certified highest level psychologist delivering this care. We may have individuals working in our clinics that can be trained on basics. So having like a stepped care model may be helpful. Now, in the world of insomnia treatment, this is kind of a pro-con debate. Who should be delivering insomnia care? Some feel it should be psychologists only. Some say individuals with a wide range of experience, like nurses, social workers, anyone with a practicing license can be trained, can undergo either workshops or be trained by a certified behavioral sleep medicine specialist. But the reason I'm bringing this up today is that we can start considering people in our clinic to train them up, to provide them with resources, but making sure that they have a broad knowledge of sleep, because certainly sleep is a broad field that can involve many other disorders and other sleep disorders that can be contributing to insomnia. So how can we get insomnia treatment in the hands of these patients? Well, certainly we can deliver this individually. Group therapy has been implemented in a lot of large clinics. We have large group formats, teletherapy, like online, on phone, bibliotherapy. There's lots of books out there. I feel like there's so much that is being published every month, really. People are coming out with other books. Digitally enhanced, supported, fully automated digital CBT-I. We can even go now into virtual reality or having an avatar or AI coming into the mix. But I think that the transition here can be wide distribution by using things like advising your patients what the latest books are, or there might be YouTube videos or social media. I'm listing here a few books that we often recommend to our patients, like Quiet Your Mind and Get to Sleep, or Overcoming Insomnia Problems. And these apps that are coming out, things like Sleepio or Stellar Sleep or Somrest, are allowing the patient to have the information about insomnia treatment in their pocket, essentially, on their phones. And the data that's coming out in terms of comparing online digital sleep programs versus in-person or telemedicine, showing comparable results. So people can certainly improve in both conditions. So there are a lot of options out there. I'm just listing a few here, whether that's within the clinic or large corporations, utilizing these apps that can be downloaded on the phone, include a sleep diary, include a lot of information about the science of sleep, and might have modules that are able to train the individual of what they should be doing for their sleep. So these are some things we feel like we are moving more into to improve the reach of CBT-I. So I'm going to start to summarize what I've said so far about the evaluation and treatment of insomnia. And that is that insomnia is a complex disorder involving nighttime and daytime symptoms that requires close assessment and management. And that our current practices for treating insomnia include two broad areas, that both pharmacotherapy and non-medication approaches like CBT-I. And keep in mind that insomnia can be treated as an independent disorder, and it, in fact, may improve other comorbidities as a result. And the future of insomnia may include more of these CBT-I digital programs or apps to just distribute this information and provide the education to the patients in a more scalable way. So I thank you very much for your attention today, and I'm happy to take questions, and I'm going to turn the mic over to Dr. Abdan.
Thank you so much, Dr. Conroy. This was a very comprehensive and very practical overview, and we really appreciate it. And I think we have plenty of time for our Q&A, so we'll move towards the questions from the audience. Thank you so much.